not have to take a break if our questions don't go on too long.
Very good point. Hello and welcome to the Health and Government Operations Committee. Today we have 6 bills and 35 witnesses. It's also the last day for us to drop bills, so we're expecting to take a break, probably around 3:30 for half an hour in order to drop bills. We might not need to take a break if we can get done with all 6 bills before then. Just a reminder of the HGO rules. The presenter of the bill has 5 minutes, and then 5 proponents get 2 minutes each, and any opposition also gets 2 minutes each. The bill sponsor can share their extra time with members of their panel. When our members ask questions, they ask 1 question per member, 1 response from the best panelist to answer the question, and the members can have a brief follow-up question if that's appropriate. Our bill order today, we have House Bill 407, 413, and 421, followed by 536, 625, and 670. With that, our first bill of the day is House Bill 407, which is the administration bill, Health Occupations, Healthcare Staffing Shortage Emergency, Declaration and Licensing, and Practice Requirements, Healthcare Heroes Act of 2022. I believe we have Jake Whitaker here to start the presentation for this bill.
Great, thank you, Delegate Kelly, Madam Chair, Madam Vice Chair, members of the committee. My name is Jake Whitaker. I'm with the Governor's Legislative Office, here to testify in support of House Bill 407 with the amendments we submitted along with our testimony. I'm joined here by Secretary of Health Dennis Schrader, the CEO of the Maryland Hospital Association, Bob Atlas, and Dr. Guyton, the Chief Nursing Officer at the University of Maryland Medical Center. If passed, HB 407 will establish a long-term framework to enable the Secretary of Health to take immediate and decisive action to alleviate future healthcare staffing shortages by declaring a healthcare staffing shortage emergency. Each of these staffing emergencies will last no longer than 180 days. The Secretary, if passed, in conjunction with the health occupation boards, will create and expedite a board licensure process to temporarily allow out-of-state, retired, or inactive practitioners and certain students to practice in Maryland. HB 407 requires that the Secretary establish the criteria for the staffing emergency through regulations. We think this is really important because the regulatory process ensures that a variety of stakeholders, including our health occupation boards, actively participate in the implementation of this legislation. I really want to thank all the stakeholders that we've been working with for months, including the health occupation boards and the industry representatives who have contributed to this bill and amendments. Finally, I'd like to sincerely thank Maryland's frontline medical workers and the clinical staff supporting the state's testing and vaccination efforts who have worked tirelessly to keep Marylanders safe. By passing HB 407, we hope to provide the much needed relief to Maryland's healthcare heroes, and for the aforementioned reasons, we respectfully request a favorable report on HB 407 as amended. And if okay with you, Delegate Kelly, I'd like to turn it over to Secretary Schrader.
Thank you, Delegate Kelly, Madam Chair and Vice Chair, members of the committee. For the record, I am Dennis Schrader, Secretary of the Maryland Department of Health. I respectfully request the committee's favorable consideration of House Bill 407 and acceptance of the consensus amendments introduced earlier. Since the beginning of the COVID pandemic, our efforts have been focused on ensuring sufficient hospital and nursing home capacity. Through the incredible work of thousands of healthcare heroes and the vigilant efforts of our state citizens, we have had one of the lowest infection rates in the state through our citizens getting vaccinated and boosted. House Bill 407 is a forward-looking bill that will provide the long-term foundation to alleviate crisis staffing shortages in the future. This will be an essential tool for future health emergency responses, and it builds on our close working relationships with the various health occupation boards, the hospital and nursing home associations, and other stakeholders. Thank you, and I urge the committee to report House Bill 407 favorably at its earliest opportunity. And we turn it over to Mr. Atlas.
Great.
Okay, I guess I'll get going. Hi, Bob Atlas here. Thank you. I should say Delegate Kelly. Good afternoon, Chair Pendergrass, members of the committee. I'm Bob Atlas, President and CEO of the Maryland Hospital Association, here today Also in support of House Bill 407, the Healthcare Heroes Act of 2022. I want to start by thanking this committee for all you do to support healthcare workers in hospitals and other care settings and at local health departments across the state. This bill is named to honor the women and men who have served more than 700 days on the front lines of the COVID-19 pandemic. We've battled COVID for 2 years, but in many ways, the past 2 months were the most challenging yet for hospitals and their caregivers. A depleted hospital workforce combined with the massive December-January surge pushed hospitals beyond limits. 15 hospitals, 1/3 of the state's acute care hospitals, were compelled to operate under crisis standards of care. Right now, the Omicron wave is subsiding. Most hospitals that have adopted crisis standards of care have moved to contingency standards, but not yet to conventional standards. This sixth surge, however, will not be our last. Our hospitals are already bracing for the next one. And our workforce challenges haven't eased. Hospitals report right now an average 27% vacancy rate for nurses. That means fewer caregivers at the bedside. The shortage affects both COVID patients and those having other serious conditions. Looking ahead, the collision of another surge with our persistent staffing shortages could once again place hospitals in critical condition. That will threaten the health care and the health of all Marylanders, and it need not be so. Declaration of a health staffing emergency is provided for under the bill, which trigger the licensure flexibilities that are crucial to hospitals' ability to care for Marylanders when the need becomes extreme. During earlier surges, similar provisions freed thousands of practitioners to step up in our hospitals and other settings. They range from nursing students to seasoned clinicians who live in other states or had expired or soon to expire licenses. That was a lifeline. On behalf of our 60 hospitals and health systems and nearly 120,000 healthcare heroes, we urge a favorable report. Thank you. Thank God, Dr. Guyton, you can go.
Sorry, Dr. Guyton is up next. Thank you.
Thank you, Dr. Thank you, Madam Chair, Delegate Kelly, Mr. Vice Chair, members of the committee. My name is Guyton. I'm the Chief Nurse Officer and Vice President for Patient Care Services at the University of Maryland Medical Center in Baltimore. I appreciate the opportunity to testify before you today in favor of Senate Bill 407 on behalf of the University of Maryland Medical System and my 29,000 colleagues in 12 hospitals across the state. I want to begin by thanking Governor Hogan for proposing this legislation. In addition to my role as CNO, I am the planning section chief for the Unified Command. And for the past 2 years, I've had the privilege of working on the front lines of the pandemic in a leadership role to care for our patients, protect our communities, and support our workforce. Every surge has carried its own unique challenges, but in many ways, this past surge was the perfect storm. Infection rates skyrocketed because of Omicron. Hospitals experienced a surge in COVID patients, and at the same time, our workforce numbers really declined. When Governor Hogan declared a state of emergency on January 4th, there was a sigh of relief. It brought much needed resources and flexibilities and the licensure requirements that helped bring staff on board to our hospitals faster and allowed us to care for our patients. This legislation, Senate Bill 407, will allow for many of the same licensure flexibilities under the healthcare staffing emergency declared by the Secretary of State of Health, which will prove to be an invaluable resource in this great time of need. I appreciate the committee's time and urge the favorable consideration of Senate Bill 407 for our patients and the community that we serve. Thank you.
Thank you. We have 2 more people signed up in support and then 2 more favorable with amendments. So we'll do the favorables together and then open up to questions. Allison Sibirowski.
Thank you, Delegate Kelly, and hello, Madam Chair and members of the committee. I'm Allison Sibirowski here today on behalf of Leading Age Maryland in support of House Bill 407, and you have our written testimony. Leading Age Maryland represents not-for-profit aging services providers in Maryland, ranging from continuing care retirement communities, affordable housing, nursing homes, assisted living, and home and community-based services. So workforce recruitment and retention have long been a challenge in our field, and it's become even more challenging due to the pandemic, as has been noted by others so far. And the flexibilities that have been in place under the state of emergency have been invaluable. This bill will support providers in having adequate staff to support quality care should our state once again face periods of time where large numbers of staff are out sick. While we work to find long-term solutions and strategies that support workforce and a stronger workforce in Maryland, we need to employ all available flexibilities to ensure that our state's most vulnerable have access to necessary care. This bill will codify some of those previous actions to address workforce shortages at all healthcare facilities. And so for these reasons, Leading Age Maryland respectfully requests a favorable report for House Bill 407. Thank you very much.
Thank you. And finally, we have Joe Dimattos.
Thank you, Chair Kelly, Chair Pendergrass, and Vice Chair Penelope Melnick, members of the committee. I am Joe Dimattos. I'm the President and CEO of the Health Facilities Association of Maryland. It's good to be joined here by my colleagues, Bob Atlas and Allison Sibirowski. You have our written testimony, so I'll please summarize and be available for any questions. The current workforce crisis predates the pandemic. From physicians to nurses aides, we faced a dramatic workforce shortage going forward, even before the pandemic. The pressures of the pandemic dramatically worsened the workforce shortage. The most recent surge proved to us yet again, and perhaps for one final time, that there is no individual hospital, nursing home, or physician's office workforce. There is one singular healthcare workforce in Maryland, and it is shorthanded, and all of us here are drawing upon it. Going forward, the length of this workforce crisis will be measured in years and not months. And this legislation will be one important tool in support of that issue moving forward. As part of the state of emergency, Governor Hogan allowed for more professionals to practice through reciprocity, licensure accommodations, and by allowing new graduates waiting for testing to practice. House Bill 407 allows the health secretary to take the kind of actions the governor did in terms of reciprocity, licensure accommodation, and by allowing new graduates waiting to test to practice. For these reasons and more, we support House Bill 407 and ask for a favorable report out.
Very much. Do we have questions from the committee for the panel? Any questions at all? I'm not seeing any hands up, so it looks like we have no questions. Okay, wonderful. We have two more people signed up to testify favorable with amendments. We have Robin Elliott and Scott. Hold on, let me make sure I'm getting this right. Robin Elliott and Scott Tippin. Is Robin Elliott here?
I am here. Good afternoon. Robin Elliott. I'm here on behalf of the Maryland Nurses Association. We are in support of the bill with amendments, and you have my amendment, so I'm just going to describe conceptually how we're thinking about the bill. We certainly think it is worthwhile to think about increased licensure flexibility in times of workforce shortage. We will note that this could be done legally now if the governor declared some kind of emergency, but this does create a new avenue. One of our asks is to make sure that the Secretary of Health is consulting with a broad range of stakeholders, which would include, of course, the facilities, the health professional associations, and others. We would also ask, there is a whole section of the bill that talks about expedited licensure. And in that section, it would allow people, the way it's drafted, who do not meet Maryland qualifications to become licensed permanently in Maryland, not just under this kind of temporary emergency. So we would like for that to be addressed. And then lastly, and I think this might just be a technical amendment, the bill says that the workforce emergency shortage could last up to 180 days. we would just like to make sure that then it's not extended to consecutive 180 days, whether it's could be declared once every 2 years or 3 years. That's something to be discussed. I would like to mention and thank Jake Whitaker, who did come to the Maryland Nurses Association and had several really in-depth conversations with me about the governor's intent. And we would very much appreciate working with the committee on this and appreciate your time today.
Thank you very much. Scott Tippin.
And if he is not clicking on, I think it's because he might be over in EHE at the moment.
Excellent. I think we also have written testimony from Mr. Tippin. So if he is not here, we will all make sure to read his testimony. Do we have questions? I don't see any questions from the committee. I'm being real slow just in case you're taking your time. Okay, so with that, there is nobody signed up in opposition. So that concludes the hearing on House Bill 407. Thank you so much. The next bill we have to hear today is House Bill 413, Health Insurance Individual Market Stabilization Extension of Provider Fee. And we have also a couple of panels on this one, a favorable panel and an unfavorable panel. Kicking it off will be Jake Whitaker. Thank you, Jake.
Thank you, Delegate Kelly. And if okay with you, if Michelle Eberly could use some of my time, I'm going to be very brief.
Absolutely.
Great. Madam Chair, Madam Vice Chair, my name is Jake Whitaker for the record with the Governor's Legislative Office here to testify in support of House Bill 413. I'm joined by Commissioner Bahrain, the MIA Chief Actuary, Bradley Boban, and Michelle Eberly, the Executive Director of the Maryland Health Benefit Exchange. The reinsurance program has been an overwhelming success here in Maryland. Prior to the establishment of this program, premiums in the individual market were projected to grow by over 200%. Since the program has began, the premiums have gone down by over 30%. Maryland now has, on average, the lowest premiums in the nation. The reinsurance program has successfully leveraged a pre-existing 2.75% premium assessment in 2019, which was subsequently lowered to 1% in 2020. This bill simply continues the assessment already being paid by insurers. It does not raise costs for insurers, so therefore this bill will not raise premiums in other markets. Simply put, this bill is a win-win for everyone where individual market premiums continue to go down and the cost to insurers and small businesses do not go up at all. So for the aforementioned reasons, we respectfully ask a favorable report on House Bill 413. And if okay with you, Delegate Kelly, I'd like to turn it over to the Commissioner.
Absolutely. Commissioner Bahrain.
Thank you, Madam Chair, Vice Chair, and members of the committee. We urge the committee to give House Bill 413 a favorable report for 3 reasons. First, the extension of the health insurance provider fee is critical to assure that the 1332 waiver that is necessary to maintain Maryland's successful reinsurance program continues. Demonstrating a reliable funding source is a core component of the waiver application process, and terminating the funding source in the middle of the first waiver period could be a significant hurdle to overcome in seeking a second waiver. Second, the contention by some that the amount in the fund is sufficient is inaccurate for reasons that Mr. Boban, the MIA's Chief Actuary, will address. And third, it is not true that continuing the assessment will raise insurance rates or harm the small group market. As Mr. Whitaker just indicated, the 1% tax, the 1% assessment is already in the rates, and continuing it is rate neutral. And every person who has health insurance in every market benefits from the stabilization of the individual market and the rate reductions achieved there. The individual market is the market of last resort and exists in large part to assure that individuals and families that lose employer-sponsored health insurance can quickly and easily acquire good, affordable, and often subsidized coverage, and all insurance plans benefit from the reduction in the uncompensated cost of care. I thank you for your attention, and I'll turn this over to Mr. Boban.
Thank you, Commissioner. Thanks to this committee for allowing me to testify in favor of House Bill 413. My name is Brad Boban. I'm the Chief Actuary at the MIA. As has been alluded to, there's a need to extend this funding to ensure that our reinsurance program has sufficient funds to operate for the next 5-year waiver period extension. There is a large range of actuarial projections, and they are heavily dependent upon what is assumed about federal funding in the future. And the federal funding has a large amount of variance in results. For 2021, for example, the original federal funding was projected to be $335 million prior to the American Rescue Plan being implemented. That's since been increased by $140 million to $474 million. But that $140 million spread is the kind of swing that federal funding can reasonably make. You know, as far as the impact on group markets, you know, as the commissioner stated, that there is no upward premium impact from extending this assessment. The 1% is already built into rates. And as far as what kind of impact that has on the market, you know, in general, the small group market has been extremely stable. The average rate increase has been a below trend 3.9% over the past 4 years. And you know, this program gives small groups another option. You know, they can participate directly in the lower premiums, you know, via HRAs, either small qualified small employer or individual coverage HRAs, allow small groups to put tax deductible funds in an HRA for their employees to purchase directly from the individual market and benefit from these premiums. Sorry for running over my time. The one last point I wanted to make is that, you know, we want to extend the waiver for a full 5-year period and, you know, not extend it for any less. You know, all waivers that have been approved to date have been for the full 5-year period. Our waiver is the most successful waiver in the country. Our program is the largest size program. We now have the lowest individual rates in the country, and we want to extend that for a full 5 years and ensure that we can continue running a program at its current size.
Great, thank you very much. Let's keep the presenter clock up for Michelle Eberly so she can use those 3 minutes. Thank you.
Good afternoon, Madam Chair and committee members. Thank you for the opportunity today to testify. You will hear other testimony from some insurance carriers that although they acknowledge the reinsurance program has brought health coverage to more Marylanders than ever, they do not want to fund the assessment in its current form. The insurance carrier's recommendation is for a 1-year waiver extension and an evaluation of who should fund the assessment. The discussion and recommendation are late in the process and have the potential to jeopardize the waiver program and the reinsurance program. Last September, I briefed the Health Insurance Coverage Protection Commission on the waiver timeline and the need for continuation of the assessment. The commission is made up of multiple stakeholders, including Kaiser Permanente and Care First. That would have been the more appropriate time to address the ongoing funding source should there have been concerns. The current waiver expires December 31st, 2023. The required timeline from letter of intent to approval is a minimum of 1 year. The process to extend the waiver must start this fall. A waiver extension is contingent on state commitment to provide state funding for the program. We are concerned that submitting a request for a 1-year waiver will not demonstrate state commitment to continuing a reinsurance program or a commitment to a stable insurance marketplace for potential new carriers. Not to mention the unnecessary use of taxpayer dollars for repeat work 1 year later and the administrative burden placed on state agencies already short on staff. There's nothing to prevent having a study group evaluate who should contribute towards the assessment and returning with a subsequent legislation during the waiver period. Not staying on track with submitting a 5-year waiver extension will jeopardize the reinsurance program, individual marketplace stability, and continued health coverage for hundreds of thousands of Marylanders. Given the aforementioned, we respectfully request a favorable report.
Thank you very much. We have 2 more people signed up in support. Deb Rivkin.
Sorry about that. I had to find myself there. Hello, everyone.
Hey.
Madam Chair, members of the committee, I'm Debbie Rivkin, Vice President of Government Affairs for Care First Blue Cross Blue Shield. in strong support today for House Bill 413. I will be brief as you have written testimony that I've submitted. CareFirst has always been a strong supporter of the state's reinsurance program and strongly supports its continuation. As you know, the program has been extremely successful in reducing premiums, increasing enrollment, and stabilizing the individual market. We should be really proud in our state for all that we've done. Before the reinsurance program, insurers were proposing rate increases year over year that were ranging from 25% increases all the way up to 33% increases between 2017 and 2019. And without the reinsurance program, individual premiums are going to jump back to those pre-2019 levels, which is going to cause individuals to drop their coverage, stay uninsured and not come into the marketplace, or ultimately increase uncompensated care in the state. We couldn't agree more with the administration, the MIA, and the exchange that this bill must pass this year with the existing assessment in the law. Because of all the unknowns and the amount of the federal pass-through dollars for the future, reducing or changing the assessment at this time will increase the risk that we're going to have a shortfall in funds in the future years of the program. We can't afford to take that risk. And so I would request a favorable report on this bill as introduced. Thank you.
Thank you. And last up is Vinnie DeMarco.
Thank you, Madam Chair, members of the committee. I'm Vinnie DeMarco, President of the Maryland Healthcare for All Coalition. We strongly support House Bill 413. Maryland is one of the best states in the country in getting people healthcare coverage under the Affordable Care Act. And one of the reasons is because in a bipartisan way, we have fully implemented and gone beyond the Affordable Care Act. And one of the best examples is the reinsurance program in this assessment, which the governor signed into law in 2018 and you all passed. That was wonderful. And then re-upped it in 2019. You've heard about how much it's done to keep premiums down. And I want to emphasize, we can't jeopardize that waiver. We have to do this for 5 years. But I want to make sure the committee understands that it's not just the reinsurance, which is great, that's been funded through this assessment, but two other measures that you enacted in 2019, one by Delegate Ken Kerr and Senator Brian Feldman, providing youth subsidies. Over 9,000 new young people have gotten enrolled in the Affordable Care Act coverage because of these subsidies. So that's been a wonderful new program, which could be jeopardized if this assessment is not there. And the wonderful Health Equity Resource Communities Law, Delegate Jazz Lewis and Senator Antonio Hayes, of course, that is in place now, reducing health inequities and putting together programs to do that across the state. That funding could also be jeopardized in the long run if we don't have this assessment. This assessment was a terrific bipartisan way to improve healthcare in Maryland. We hope that you will continue it for the next 5 years with House Bill 413. Thank you very much. And I just want to say, we have the best health exchange in the country. They're doing a great job and we love working with them. Thank you.
Thank you very much. Do we have questions from the committee for this panel? Delegate Shalega.
There we go. Thank you, Madam Chair. This question would be for Ms. Breen from the MIA. What are your thoughts on a 1-year extension rather than 5?
With your permission, I would like to defer that to either Mr. Broban or Ms. Eberly, because I think
that's fine. Whomever you think. Okay.
Michelle, do you want to take that, or do you want Brad to take it?
Brad can take it from the numbers perspective.
Yeah, I can take it. I mean, I think a waiver application has to be complete, whether we apply for a 1-year waiver or a 5-year waiver. And part of a complete application is actually a 10-year projection. And so I think if a 1-year waiver was pursued, you know, it's not something that could be done quickly or easily. As Michelle said, you know, we would need to start preparing it, you know, this fall with a letter of intent. And it would be just as much work as a full 5-year waiver. But it would add the extra risk of, you know, not having the funding for beyond the first year, and the projections would necessarily have to reflect that uncertainty in funding, and the projections would look a lot worse, and would probably show that we would need to, run a smaller program. And so I think in general, I would highly recommend doing a full 5-year waiver extension. That's what's been requested for and approved in all the other states that have done waivers. And it will allow us to not duplicate work and the not insignificant effort that's going to require to submit this waiver extension.
Thank you.
Thank you. Delegate Collison.
Thank you very much, Madam Chair. And I want to thank the panel today for being so clear about their position. I've spent the last couple of years just really trying to figure out insurance, but I will say I've not talked to one entity, company, organization that does not want the reinsurance program to continue. So just to be clear, there's no one who does not want this program to continue. Everyone wants it to continue. And we wanted to do it in a really responsible way. I remember when we set the assessment, and it was somewhat arbitrary. We didn't have real actuarial numbers. So I think this is for you, Brad, since you're our actuary. We haven't actually, to my knowledge, or at least I haven't seen, a real assessment of how much we need in the reinsurance fund going forward over time. And, and I understand the uncertainty about, and appreciate the uncertainty about the federal funds, but that's what you actuaries do all the time. You figure out that uncertainty when you build the program, when you build when insurance companies build rates, they do it based on their best guess, given the information they have. So I guess I'm asking, is the 1% the right number? And to pay for the reinsurance program and in going forward. And is there a way to think about how do we measure what we actually need?
Yeah, thank you very much for the question. I'd like to just start by saying that, we only have 2 years of actual program costs in the book. We still do not know the final 2021 program costs. So the first 5-year waiver period, we only know how much it costs in the first 2 of those years. And as far as uncertainty and actuarial projections go, you're absolutely right that the actuarial projections are always, probabilistic and have underlying uncertainty. With that being said, part of actuarial projections are doing a wide range of scenarios so that you can encompass the best case, the worst case, and try to find where your best estimate is. And I can tell you that there are certainly financial scenarios where the 1% is sufficient and more than sufficient, and the state funds will continue to grow over time. But there are also many reasonable scenarios where the 1% is not sufficient, and where that with a 1% assessment in place, that we will not have enough money to fully fund the program in its current size. And we will be forced to make the choice between raising the assessment additionally or lowering the attachment point and lowering the effectiveness of our program. And our program is the largest in the country. No other program is targeting a 30% premium reduction. And that is the safety valve that's written into the waiver. If we do not have sufficient funds to run the program with its current parameters, we need to change the parameters to what we can spend. And that's the real risk, that's done so not in a measured, planned fashion, but because we run out of money. And that's what is essential to ensure doesn't happen. So it would definitely be reasonable to have some kind of trigger to say the assessment can be suspended. The state of Delaware has a condition where if they have 5 years of funding in the state assessment, they suspend further assessment. And that's enough to run the program for the whole 5 years with no federal support. And that is definitely sufficiently conservative. And we could probably have a threshold that's less than 5 full years of funding. But, I would suggest that before we talk about not continuing the assessment, we would make sure that we have at least several years of funding. And to put things in perspective, at the end of 2020, the last year that is finalized, we have total funding available to us of just over $412 million, a little bit higher than that. And that's a little less than 1 year of program cost. 2021 is projected to cost $432 million. So we have approximately 1 year of program costs that we have assessed in past years and are currently waiting to be spent. And I would suggest that that's not conservative enough. And before we talk about not extending the assessment, that we need to have at least 2 or 3 years of program costs to give us sufficient cushion that even if the federal funding declines significantly, that we would be able to continue to run the program at its current size.
May I follow up, Madam Chair?
Absolutely.
Real quick, Brad. So we would have the ability, first of all, I am not suggesting we stop the assessment. So please do not characterize it that way at all. I am seeing a need for continued assessment. So I'm just trying to figure out what that assessment should be. And so we would have the ability, though, if we went, say we continue with the 1% now, and go for the waiver and get it for 5 years. In 3 years, we could say, we have 5 years now in our bucket. Can we change the assessment at that point? We would be able to do it inside the waiver. Is that right?
Yes, we have the ability to modify our funding within a waiver, and we've already done that for the first waiver. I mean, if you remember, we originally had 2.75% 1 year only fee, and we got that waiver approved. And after that was approved, we instituted the 1% from 2020 through 2023. And so, yes, we absolutely could at a later point, say that establish a threshold, and if the funding gets to a certain level, we could say that we're going to suspend the assessment until the funding dips back down below. And CMS would allow us, we keep them updated. Michelle and the Maryland Health Benefit Exchange is in constant contact with CMS and is giving them updated projections, on a regular annual basis throughout the waiver. And so, yes, that would absolutely be a possibility.
Thank you, Brad. Thank you, Madam Chair.
Absolutely. Vice Chair Melnick.
Thank you, Madam Chair, and good afternoon. I would like to ask a question just for the committee and myself, if you can explain. We have this reinsurance program, and it has been extremely successful. Can you tell us where the money goes? Who does that money go to? What is it used for? Who's the best person that can answer that?
So, Madam Vice Chair, if okay with you, we could turn it over to either Michelle Eberly or Commissioner Barang.
Thank you very much.
Thank you.
I'm happy to take that. So how we calculate where the money goes is every year the carriers submit reports to us to show us how many of their members hit those factors of the reinsurance. So they hit that $20,000 attachment point, and between that and $250,000, the reinsurance fund pays 80% of those claims. So it's payable, it's paid out to all the insurance carriers that participate in the individual market, and for any of their consumers that have reached that $20,000 point, they're going to get 80% reinsurance for any claims for that individual person between $20,000 and $250,000.
Thank you.
Next up is Delegate Lewis.
There we go. Thank you. Thank you so much, Madam Chair, and thank you to all the panelists. My question is this. I'd like to understand a little bit better what's involved in completing or filing a 1332 waiver. I have a vague sense that it's a complex process, but before we talk about, shortening the time frame, I'd like to know how much work is involved. Whoever's best to answer that question.
I'm happy to take. Oh, I'm sorry.
Please go ahead, Michelle.
I was just going to say, I'm happy to take that question since we've done it. It is a very, very intense and long process. So the federal guidelines set up the whole requirement, the whole process for how you apply for a waiver. It starts with a public notice. We have to submit a public notice. We have to allow for a 30-day comment period. We have to have 2 public hearings. We have to get state legislation that would allow us to apply for the waiver. We have to complete a full actuarial analysis, which requires procurement. So you have to do a procurement to be able to get those actuarial services. And then we need that full analysis of, what the cost is going to be, what we're going to need, how we meet the parameters of the federal requirements that we're going to provide coverage for at least the same amount of people, if not more, for at least the same cost or less. So there's a whole formula involved. We also need an economic analysis, which again, we need to procure services for, that talks about how we're not going to increase the federal deficit. So that's another component. And then all that data and all those assumptions and the whole application has to be submitted to CMS. So that timeline, obviously you can see for preparation, for analysis, that in and of itself takes about 8 months. Then once you get through that, you submit it to CMS. Now CMS has 45 days to deem the application complete. So if for whatever reason you've missed a step or you don't have the information they want, you have to go back through a reiteration process. Once CMS deems that application complete, then they have 180 days to review the application and make a decision. So that's why at minimum, it's a year process from start to finish, from when we start the process, get all the analysis, submit the letter of intent, and get the final approval. So it is a long process. It costs a lot of money. Those actuarial analysis are about $100,000. So it costs an awful lot of money. And we had the exchange of the benefit when we did this the first time, that I think we were third in line, second or maybe second in line to do the waiver. Now, many other states have done that. And in looking at the time period that we have to file the waiver, there's 7 other states that will be also filing their waiver renewals. And CMS, of course, has limited staff. So the expectation that we'll be able to get something through quickly is not very realistic. And in addition to that, CMS is right now in the process of a lawsuit with Georgia over their 1332 waiver. So that's another time constraint from what they've told us on their staff as well. So we need to really realize it will take at minimum a year for this process.
Thank you. Thank you, Ms. Eberly. And if I may, Madam Chair, a quick follow-up.
Sure.
Thank you. So given the complexity of the process, I mean, this is way more involved than applying for a bank loan for a business or something, or even a grant application. This is so involved, and it requires legislation, as you mentioned, Ms. Eberly. How would the state of Maryland appear to CMS or to carriers if we only applied for a one-year waiver? Would that make us look serious or unserious, having put all that effort in?
I'll follow up on what Brad had said, that there's been no one else that has submitted a 1-year waiver. Everyone else has gone in for a 5-year waiver. The concern for me and my role with the exchange is, what does it say to our consumers? What does it say to our federal government? What does it say to any potential insurance carriers coming into our marketplace? That are we committed to this program or are we not? We can't submit the waiver and say, well, we're going to put it in for 1 year while we figure out how we want to fund it, because we can't put that caveat out to the public. I mean, we're going to submit a 1-year waiver. So that's my bigger concern. You know, we've built so much credibility with this program and for the state, that to go in with a 1-year waiver just really invalidates a lot of the hard work we've done.
Madam Chair.
Are you good? Okay. Delegate Kipke.
Thank you, Madam Chairman. Question for the exchange, whoever is the most appropriate person. I recall that we had issues with a number of providers in the individual group market. There were very few, and that gave me some concerns about competitiveness. Since this reinsurance program has been implemented, obviously that market should be healthier. More people are being attracted to it. Has that changed anything in the way of the number of carriers that are participating in the group? I mean, I noticed there's one that's very much a proponent of reinsurance, and the others seem to, be less supportive. Is there, have we done anything to improve competitiveness, bringing in more competition in the individual group?
We have brought in one additional carrier. It's a return carrier, United Healthcare. They entered the market last year in several regions, not fully statewide. And so they kind of dipped their toe in. This year they did go statewide. And just between last year and this year, their enrollment growth was over 400% going statewide. So they did see that increase. And again, I will just go back to from when we started, the first year we had the exchange, we had 85,000 people enrolled. We now have over 180,000 people enrolled. That's due to, the marketing efforts we do, the costs that we've been able to drive down. So everyone has gained market participation by that increase in enrollees.
As a quick follow-up, if I may, how do we compare to other states with I'm tempted to say with the reinsurance program, but how do most states have a very limited number of carriers in that market on their exchange?
No, there are other carriers, California and Washington. They have many more insurance carriers in the marketplace. And however, I don't think it's simply the cost of premiums that are driving that, because of course in Maryland we have the lowest premiums in the nation. So there's other factors in Maryland that I think affect those decisions.
Yeah. Thank you, Madam Chairman.
Much. Delegate Krebs, and then followed by Delegate Saab, which will be our last question. Delegate Krebs.
Thank you. I remember when this reinsurance all came about, at first I was very confused of a lot of the terminology, reinsurance and 1332, but I do understand it now. And let's just, for discussion purposes, assume that the program has gone well because it's heavily subsidized now. So of course you can bring rates down when you're subsidizing them. So that's sort of a given. However much you put in, you can bring them down. My concern comes from, where does the money come from? Where this premium tax, this assessment, to me, it's a tax. It's an assessment on certain people. And I think the prior speaker alluded to, what's been the impact on them. So my question to you guys is, it says in the testimony, it's small business and individuals and families who purchase their own insurance who this provider tax, and it's a tax on their policies, that's who's paying it. And so why, if we think this is so important, why not either broaden the base of who you're assessing or taxing, or take it out of the budget so there's transparency and everyone's footing the bill versus this very small group of small businesses or individual market. So, I mean, that's my question. It seems like I thought it was going to be temporary, and now it seems to be wanting to go on for a long time. Why not find another way to fund it versus taxing one group of people's insurance and then giving it to another group of people's insurance? Is that discussion ever taken place?
Delegate, if okay with you, Mr. Bobian can speak to this assessment that's been declining over the years.
Yeah, I can speak to that. Just to clarify, this assessment was originally established in 2019 to replace a federal assessment, which was being put on a one-year moratorium. The federal assessment applied to the same markets that we are applying the state assessment to. And to clarify, this is a broad-based assessment on all fully insured business in the small group market, the large group market, the individual market, in medical, dental, and vision. And it also applies to Medicaid MCOs. And so overall, this assessment is being assessed to, slightly over 2 million individuals are helping to pay this assessment. There are segments that are not paying the assessment, namely the self-insured, the federal employees, and Medicare enrollees. And quite frankly, we do not have the state statutory authority to levy this assessment on any of those. And those segments also do not pay the state premium tax. This comes down to statutory authority. I will say that for whatever reason, the federal assessment, that the feds do have the ability to assess this on self-insured, and on other assessments, they have taxed uninsured, self-insured, but the federal assessment that our assessment replaced did not, in fact, apply to self-insured. It only applied to fully insured. But that's the genesis of our assessment. That 1 year there was a moratorium. There was the option to have our state assessment replace the federal assessment that was being put on moratorium in a rate neutral manner. And the assessment was designed to replicate as closely as possible to the pre-existing federal assessment. And as far as going forward, I think our concern is having something that can be implemented as smoothly as possible. And this assessment is already in place. The infrastructure, we are already collecting it. We can, without any additional work or effort, continue to collect the assessment, where any other alternative funding method would require the structure for collecting that funding to be created. And so I'll leave it at that.
And I'm going to one follow-up question. I mean, I agree that this was a very easy, the federal tax went away and we just took it on and said, let's just keep taxing those people more. I disagree with the policy, but I guess the thing that has not been answered is what impact has that had on these other people's premiums, small group, individual market? And we haven't really said in general that it's broad-based. Medicaid obviously is state paid. So Medicaid, basically, we're taxing ourselves, the state taxpayers. So what impact is it that those people are continuing to pay a tax to subsidize someone else? And again, I know it's an easy way to do it, but why not take it out of the budget instead of continuing to tax the same people again? That's my question. And I mean, maybe I know it's easy, but other than that, is it been considered?
Yeah, I mean, on a high level, in 2018, the last, prior to our assessment and when the federal assessment was in place, carriers were building in on average 2.75%. Today, our assessment stands at 1%. And so in general, there's been a 1.75% rate reduction from the assessment being put at a lower level than previous. And while, rates could be lower without the 1% assessment, there's no evidence that this assessment is causing any adverse effect in any marketplace. Small group rates have been stable and increasing at a low pace. And in general, there is a wide range of small group rates that if you look at the bronze level narrow network rates versus the platinum level broad network rates, you can buy a small group policy with a range of 100%. The cheapest rates are half as expensive as the most expensive rates. And there's no evidence that the 1% marginal assessment is in any way impacting the overall affordability of the marketplace. And all participants in the small group marketplace are paying the same assessment and are on a level playing field. And so there's no indication that this has had any impact on small group competition. There are just as many carriers offering small group plans now as before, or on small group retention.
Thank you.
Thank you. Chairman Pendergrass has a question. Madam Chairman.
Thank you. So I think we need to go back to some basics on this and be reminded what the 1% is matched by from the federal government, because to think that the 1% is subsidizing everybody's reinsurance, I think is, and correct me if I'm wrong, incorrect. We get a fairly decent match, which then adds more money into that reinsurance pool, which means that we get better rates for the people who are in the individual market. But the more people who are insured, it means the less people are in the system as uninsured or charity or whatever word you want to say. So we have actually more people paying the rate. So if you could sort of explain the economics of this, particularly by starting with the match and how it impacts the market. And it might be between an actuarial and the insurance commissioner, I'm not sure, but it's important to remember the basics, where this came from, and the fact that we did go down from 2.75% to 1% when we found out that seemed to be the realistic number that we needed.
Go ahead,
I think I can handle that if that's okay.
Fine.
Yes, as far as the federal funding goes, in general, every dollar that a state invests generates anywhere from $1 to $4 of federal pass-throughs. Looking across, all the states, all the 14 states with pass-through, with 1332 waivers in their experience. Maryland has historically been on the high end of that, partially driven by the ambitious size of it. But over the 5-year waiver period extension that we're talking about, about $700 million in state assessment is projected to generate about $2.8 billion in federal funding. So that's $4 of federal funding being generated for every dollar the state invests. To another point you made, yes, to the extent that the reinsurance program is providing a stable individual market that is helping keep the uninsured rate down, that is leading to a reduction in uncompensated care that is being directly benefiting all of the small group and large group markets. And that, uncompensated care pre-ACA was several percentage points higher than it is in its current state. And that, the more we can drive down the uninsured rate, the more uncompensated care we can remove from the hospital rate setting process. And that directly benefits, all market segments. And I think that answers your question directly. I'll leave it at that.
It does, and I'd like to ask, if I may, Ms. Rivkin, to follow up with one piece of history as well. My memory is we were going up, and we worked very closely with Care First and determined that if we actually brought rates down, the more we brought rates down, the higher the match would end up being, I think is the way it was put. But the better we did was what it amounted to. Can you kind of explain the mechanics of that if you can remember?
Yeah, Brad, honestly, math is not my forte, so Brad may be better at this than I am. However, that's absolutely correct. The less money, when rates go down, the less money the federal government had to put in. So instead, they gave it to us in our reinsurance program. So the lower our rates went, the more money we would get from the federal government. It's a complete correlation between the two. And the other thing if you don't mind, in the Medicaid market, and Brad, correct me if I'm wrong here, I believe we get the assessment on Medicaid, we get 2/3 from the federal government as well. So it's not just coming from the state. There's if you want to call it a windfall, we have more federal money coming in for the Medicaid piece of the assessment as well.
Because they're basically rewarding us for the money they've spent in that program.
Right.
I think that about sums it up, but if you have something to add, thank you, Madam Chair, for your indulgence.
Absolutely. Delegate Morgan.
Thank you, Madam Chair. And piggyback on what the chairwoman just said, I wanted a little history lesson on this so I could just refresh my memory. The reassessment was originally a 1% tax from the ACA on carriers that was removed in like 2016, 17, something like that, if I remember correctly. Is that true?
So I can answer that, Delegate, if you'd like. So the assessment was originally 2.75% under the federal assessment. The 2017 federal tax cut bill eliminated that assessment permanently in 2020. So now carriers are only paying the 1% assessment, and they'll continue to do so under this bill.
Okay, and that's when we took the 1% I guess in 17 and used that to set up. So it was a prearranged tax in the ACA that was given back to the carriers, but we basically diverted that tax. We stopped that tax cut from going into effect and diverted that money to set up the reinsurance fund, correct?
So we leveraged the existing assessment from the feds, and then we've subsequently lowered it by 1.75% since the program began.
Gotcha. Thank you. Thank you, Madam Chair.
Absolutely. That looks like all the questions. I will make sure nobody else is raising their hand. Wonderful. Thank you for this panel. And now we'll move on to the unfavorable panel, starting with Matt Celentano.
Thank you, Madam Chair, members of the HGO Committee. My name is Matt Celentano, here today on behalf of the League of Life and Health Insurers in respectful opposition to House Bill 413. I want to make it very clear from the beginning that every single health insurance carrier in Maryland is in complete support of the reinsurance program. It has done what it's intended to do. It saved the individual market from complete implosion. It's reduced premiums for Marylanders and it's become a stable marketplace. We're in complete support of that program and think it should continue 100%. That being said, we are here today in opposition to the tax, not the program. We believe there are better ways to fund the program that will not have as much impact to other aspects of the insurance landscape in Maryland. Simply taxing one stakeholder in a diverse playing field of healthcare stakeholders is not the direction we think is fiscally prudent. Also, the circumstances of the program have completely changed. We passed the funding mechanism a few years ago to prevent a disaster. The house was on fire. We are in a much different place now with a stable market that has seen further influx of federal dollars and subsidies available to consumers. We've also seen we have seen dramatic fund transfers out of the program as we've raised far more money than needed to meet and exceed the obligations of the reinsurance pool. We have plenty of ideas how to fully fund the program, which we all want, without just taxing the carriers the 1% as proposed in this particular legislation. Every healthcare stakeholder benefits when more Marylanders have coverage. We've heard that earlier today: consumers, hospitals, carriers, doctors, drug manufacturers, et cetera. And we can surely take the time to make sure we get this right. We think this is especially true as the current program doesn't expire until the end of the 2023 calendar year. And even then, there will be a projected surplus of a few $100 million. We've been in touch with the governor's office, the exchange, the MIA, and members of the Maryland General Assembly to try to develop a solution that fully funds the program while limiting the impact to other marketplaces. We promise to continue to do the work on these proposals to continue progress, but we respectfully urge an unfavorable report to the bill as introduced. Thank you.
Thank you very much. Next up, we have Ruth Williams Brinkley.
Delegate Kelly, Ruth was not able to join us today.
Okay, well then let us move down the list to Shannon McMahon.
Good afternoon, everybody. I'm Shannon McMahon, members of the committee, Madam Chair, Delegate Kelly. Thank you for having me. I'm Shannon McMahon. I'm the Executive Director of Medicaid Policy at Kaiser Permanente. First and foremost, I just want to reiterate what Mr. Celentano said, which is that we're here to support the reinsurance program. We're here to talk about the funding mechanism, and that is where our opposition to this legislation comes in. And I think it's important for me to say that I'm the one who planted the idea of the one-year extension of the 1332 waiver. And I want to be crystal clear with the committee to say that in my new role at Kaiser Permanente that I've been at now for 4 years, feels new, we've worked with many states on their 1332 waivers and on their Medicaid waivers. There are many Medicaid waivers that were extended for 1 year. There are plenty of opportunities for states to work with the federal government on 1332 waivers and on 1115 Medicaid waivers. What we do know for sure is that the state has time. In fact, when this waiver was first approved, was first worked on, you all passed that legislation and the waiver was done by the end of the year. It was a crunch. Plans did have to refile rates, but there's a way that we can really look at this and spend more time looking at the financing of this so that we're not in a situation of saying there's $200 million on the books. Is that really the money that we need for this program? It happened last year where there was $100 million sitting on the books, and that ended up going back into the Medicaid program rather than funding this program because the estimates of what was needed for this program were overinflated. And so we'd submit to you that spending more time figuring out what that need is really critical. And so we're here to say we're ready to work with you. We're ready to work through that and work with the exchange and other stakeholders. But we really want this to be a very thoughtful process about what's needed, what's what's on the books now and what can be leveraged moving forward. So thanks very much for the opportunity, and I'm happy to answer any questions that come up.
Thank you so much. Always nice to see you. Kim Robinson. Is Kim here?
Here I am. And hello, Delegate Kelly and members of the committee. Kimberly Robinson, Regional Director of Government Affairs for Cigna, here also in respectful opposition to the bill as introduced. Cigna, again, is supportive of reinsurance programs and supports the extension of Maryland's program. I think something that's being lost in this conversation is that our opposition is not about funding the program going forward. It's about how the program is being funded going forward. And so you've heard that this program is funded only by individuals and businesses who are buying insurance in the regulated market. And I think there's important that we understand who we're talking about. According to the MIA's own data, by their most recent report, which I will admit is a year behind because the most recent one doesn't seem to have been posted, but by the most recent report, there were only 351,722 business group insurance contract holders in the state of Maryland. In a state of 6 million people, in which every single Marylander benefits when uncompensated care goes down, you're asking 351,722,000 policyholders in the business community to be the ones to fund this program. Even adding in the individuals who have a push and pull because they benefit by the lower rates, but they're also still being assessed for it, you still don't come past about 500,000 Marylanders who are being personally charged to fund this part of the funding for the program. And so when we talk about changing the funding, we're really talking about making it equitable when it comes to how the state is dealing with this in a state of 6 million where everyone benefits and a small group is carrying the weight. And so for that reason, we think that it's important to understand that, yes, it's not a new tax. And yes, as you heard, it's baked into the rates already, but it's baked into the rates already. And just as the rates could go down by the 1.75% when you reduce that, any change, any guardrail, any restriction here also has a positive impact on those rates for individuals. And we think that's really important for the committee to consider. It's been talked about as something that should be discussed in the past, but there's not ever been a really focused work group doing actuarial work to understand it. And with that, I will end my testimony because my time is up. Thank you so much.
Thank you so much for respecting our clock. Allison Taylor is the last person to speak.
Thank you, Madam Chair, members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente. You have my written remarks, but I wanted to deviate from what I was going to say and respond to a comment that was made by Ms. Eberly earlier. As she noted, Kaiser Permanente is on the Health Insurance Coverage Protection Commission. However, I did want to correct the record that we have objected in the past to this assessment. When the recommendation came up in 2020 with the commission's report, Kaiser Permanente did object at that time to a recommendation to continue the assessment. Ms. Eberly referenced a meeting in September of the commission where this proposal was discussed, and we followed up and had a meeting 5 days later with her where we did indicate that Kaiser Permanente did not support the assessment. And so I'd like to correct the record to show that we have raised that point. We're here in good faith. And so, the reason it's important to Kaiser Permanente is we have 460,000 Marylanders in the state. Nearly all of them, over 99%, are in this regulated marketplace that's fully insured business that is paying this assessment. So it's critical for our members. Our members are paying this tax in the way that it's it is baked into the rates here. And so we think it's totally appropriate for us to be raising this concern. This is a tax on health insurance that's going to pay for health insurance. We don't think it's unreasonable that the committee grapple with that fact and think of whether that should be reconsidered and how the program should be funded going forward. So it's great working with you and appreciate the time. We continue to be at the table and in full support in trying to find something that works here. Thank you.
Thank you so much. Do we have questions for this panel from the committee? Delegate Hill.
Thank you, Madam Chair, and thank you all. It's good seeing you all. So here's the thing. As you all said, there have been issues with the funding approach for years. And you all, as a panel, are some of the brightest folks that I know in this area. Depend on you guys a lot to keep me straight. So Matt, you talked about needing more time, and Shannon, hey, you talked about, you're the one that suggested we just go for a waiver for 1 year to give more time. And I'm trying to figure out how for the last 3 or 4 years, you haven't come up with a suggestion for how we can do this better. And maybe I'm wrong, and that this is a new problem, but it seems like the same problem that you guys have been appropriately, raising alarms about for a while. And so I'm not clear that how another year is going to get us to a different solution if we haven't gotten one so far. So whoever wants to answer that question, please.
I'd be happy to take that. Thank you for the question, Delegate Hill. When the state passed the 1% assessment, part of the language that was added to the Health Insurance Consumer Protection Commission was that if we had the second iteration of the waiver, a second 5-year period, there was language added in the statute that would ensure that we had a discussion about a broader base funding source. One of the challenges of this process has been that the carriers don't feel like we ever really had that discussion. There was presentations about what is happening across the country and in other markets, but we never had a discussion about what would be the most prudent for Maryland, and especially because of Maryland being its unique nature with the global budget and the waiver. Maryland's just different, and we did not get a chance to have that conversation. That being said, we have presented lots of different ideas for what we could do in the future. You heard earlier from Delegate Krebs, I think what happened just this past year in their reinsurance program in Virginia, they passed it to the general fund. It is the broadest base. To stretch it out across the broadest base makes the least impact across all markets. But if that's not to your fancy, there already is a model in Maryland that we could use, and that's the Prescription Drug Affordability Board that you all passed so brilliantly a couple of years ago. And the assessment for that board was to broaden the assessment as widely as we could. We taxed a little bit to the health insurers, to the PBMs, to the drug manufacturers, the hospitals, everybody in the healthcare universe. If we did that in this space, you would lessen the impact to the markets. As I had said to a couple of people, carriers don't mind paying for good programs. We just don't think it's prudent for us to be the only ones that pay. There are specific examples out there across the country that we could utilize in this space, like Delaware that was mentioned before, where you raise a certain amount of money and then you cap it. So you don't have to raise more money. So it becomes sort of a healthcare slush fund in a way, which we don't want to see happen. We could also use the time we have over the next year. The waiver is not due till March of 2023. We could look at what the right assessment would be from a carrier perspective to fully fund the program. We know it's less than 1% because we have had excess funding. These are the kinds of ideas that we've had. We have more of them, and we would love to talk about them. And because we don't think we need to do anything until March of next year, and like Ms. McMahon said earlier before, the last time we passed the reinsurance waiver, you all took great action during the legislative session, and a couple of months later, it was approved. It can be done. And we are committed at the table. Once again, we want the reinsurance program to continue. We are not opposed to the reinsurance program. We're just opposed to this particular tax.
Thank you. Thank you, Madam Chair.
Delegate Lewis.
Thank you, Madam Chair. For better or for worse, Delegate Hill and I, our minds sometimes travel the same path. I was on the same line of questioning. It occurs to me, though, having heard Mr. Celentano's answer, it makes me wonder if what is the risk if this bill, as introduced, were to pass? Is there some risk that carriers might vote with their feet and find this, how did Ms. Taylor put it, tax on health insurance for health insurance, an onerous burden that would drive them out of Maryland's market? Because I mean, not to be catastrophic, but I've had a bad day and I'm feeling catastrophic. Is that something we're worrying about? And whoever's best to answer that question. I was thinking Mr. Celentano, but whoever's in the worst mood, answer that one.
I don't I would say that's the reason why, but I just want to share can I share some data with you?
It's good to see you, by the way, Kim. Good to see you.
It's so good to see you as well. So this is not in any way to assert that this is in response to this, but I think it is important, again, in understanding from data what our markets look like, and again, who is being taxed and how that works. Again, going back to the MIA's report, this is a market that definitely does respond to costs, and despite anybody's feelings about what's affordable and what's not, and where people end up and what their options are, self-insurance always remains an option to groups. And so in the same time period that I gave you the numbers for who was actually paying the tax, the numbers of covered lives in the group insurance market experienced a decrease of nearly 100,000 people, 91,564 covered lives left the market in that time. But at the same time, in the self-insured market, you saw an increase of 145,639 covered lives. So you had a 13% decrease in the fully funded market. And so do I think it's realistic to say carriers are going to up and leave over the 1% tax? No, I don't think anybody's leaving the entire state and all of their business for that reason. I think when we speak up, we're speaking up for the people who pay the tax, which is not us. It is those constituents, it is the policyholders who are paying it, and it's those businesses who are going to make decisions about how they're going to purchase their insurance. I don't know that I think small businesses would want to make the decision to dump their small group policy and move to a HRA where they send their employees off to get individual insurance as a satisfactory response to concerns over price, even though that was suggested as an option for them earlier today. So I think that's where some of the sensitivity comes from. It's what's happening for consumers and what's happening for purchasers.
So much. Thank you, Madam Chair.
Delegate Cullison.
Thank you, Madam Chair. And so I guess I'm afraid I'm beating a dead horse here, but I'm not quite sure it's dead. So I'm going to Kim. And so just in terms of who's paying, I heard that there wouldn't be any additional financial impact because these rates are baked into the premiums currently. But if the number were to change, either up or down, if the number went down, would the premium rates necessarily go down?
I mean, I think even Mr. Boban from the MIA reflected that when it was 2.75, we baked in 2.75. When it became 1%, we stopped baking in the extra 1.75. And so now we bake in, as in their words, the 1%. If it went to 0.7, we would bake in 0.7 instead of 1%. And so that is how it's collected. It is a pass-through tax. We take your premium, we add that percent, we collect that money, we send it to the MIA. And so I think all of that is really important. And I think that there's some confusion. I guess maybe let me say this. I'm confused about what the needs of the program are, because on one hand, we've been told that we've only realized 2 years worth of claims and we don't know how much money is going to be needed. And yet at the same time, we were told that we've got all this surplus, so it was okay for the state to take more than $100 million out of the fund last year. So I also think that there's probably some clarity to understand what really are the needs and then build a program that's only taxing what's needed, especially if we're going to continue to only target a very small part of Maryland's population to be financially responsible for the program, at least part of it. We know Medicaid and the state is kicking in through Medicaid and that's being matched. But for this part of it, that's going straight to constituents' pockets, why wouldn't we want to be as conservative about what we're charging them as possible?
Thank you.
Excellent. Delegate Lewis Young. I think you're on mute, Delegate Lewis Young.
I've got some sticky keys, sorry. I'm confused about something. I see the Care First is supporting this methodology, but this whole panel is not. So I'm going to make an assumption that it has something to do with the financial ramifications of this approach. So my question is, how does it affect the rest of you negatively, but it does not affect, presumably, Care First in that manner? And anyone could answer it, or I'll ask Ms. Robinson to answer it.
I'm happy to answer too.
Okay.
I would actually defer to Allison.
Okay. So for Kaiser, one problem with this is, as we've all been discussing, it's a tax on fully insured business. It doesn't impact self-insured, which is by far the vast majority of the market here. Kaiser doesn't really have any self-insured business. We have, as I said, over 99% of our business is in the fully insured market. So it impacts, so we're essentially, our members are all paying this assessment, whereas for our other carriers, a lot of their members are not paying this assessment. So for us, it's a little bit more of a critical issue for that reason. And so that's part of the reason of our opposition today.
Thank you.
And now Delegate Penelope Melnick, Madam Vice Chair.
Thank you, Madam Chairman. I have a question, I guess, for Kim, and good afternoon. When you were talking about the number of people that were impacted by the fee, were you talking about the number of people or the number of contracts? Because the number that Brad gave is different. So what is the number of people, according to you, that are affected by this fee, not the number of contracts, because there's a difference.
Sure. So if you do the number,
so that it's clear.
Yeah. So if you do the number of contracts on the group side, right, and then the individuals, the number Michelle gave is probably more up to date than what the MIA has, because I think hers is a little bit higher because it's the current year. And like I said, this has a year lag. If you do it by the number of people, it takes your 355,000-ish contracts up to about 600,000 people. So if you were to add in the individuals, you're just slightly over 10% of Marylanders who are being assessed the fee for all 6 million Marylanders, right? So 600,000, it was like 607,000 individual heads who were in the group market. Add in 150 to 181,000, depending on which year you're looking at, members in the individual market. That gets you up to under, or just maybe around 800,000-ish. So somewhere between 10 and 12% maximum of Marylanders who are the heads being assessed. Of course, in the group market, we know a lot of our employers try to help offset the cost of their employees by contributing. So they're the actual contract holders, which is why the number is less, because it's the policy holder versus the employees.
And the employer helps pay for some of those, correct?
Sometimes, not always, but sometimes. I think it varies in the small group market. I know that NFIB also signed up in opposition, but wasn't selected to be able to speak today. So I know for those who may be interested, that would be a really particularly good resource to talk about how the small groups deal with covering the premium for those who are choosing not to shuttle their employees to the individual market, but keeping them covered. Employers will often try to contribute something. Not all can afford to, but sometimes what they do is they do try to arrange the insurance. Mm-hmm. So sometimes they're fully passing the premium to employees, sometimes they're sharing in it.
And if I have just another question. So tell me something, who pays out of all of you, including Care First, and all of you that are testifying today, who pays the biggest amount of the assessment? Well, what's the company that pays the biggest amount of the assessment, if you know?
I don't know offhand. I'll be candid. I suspect it is likely Care First, who is also receiving the biggest benefit because they've got the largest population of high-risk individuals in the individual market. So, they're on both sides of that equation, yes.
Thank you.
All right, that looks like the last question we have for this panel. I see no more questions. So that concludes the hearing on House Bill 413. We have 4 more bills, and it is almost 3 o'clock. So let's do one more before our 3:30 break. Hopefully we can break still, around 3:30. We'll see. It's not too many people on this bill. So this is House Bill 421, out-of-state healthcare practitioners, provisions of behavioral health services via telehealth. And we are going back to Jake Whitaker.
Thank you, Delegate Kelly, Madam Chair, Madam Vice Chair. For the record, my name is Jake Whitaker. I'm with the Governor's Legislative Office, and I'm joined by Dr. Elliott Jones from the Behavioral Health Administration. We're here to testify in support of House Bill 421. Since taking office, the Governor and Lieutenant Governor have remained committed to addressing the heroin and opioid epidemic, including expanding access and reducing barriers to critical behavioral health and substance use disorder services. House Bill 421 allows out-of-state practitioners to provide behavioral health services to Marylanders via telehealth. The last few years have shown that the need for mental health and substance use disorder services has only grown. To be clear, this bill is not aimed at undermining or interfering with any of the existing interstate compacts. We simply want to create a pathway for providers who are living in states that are not participating in some of the compacts. We applaud the boards for the hard work that they've done in establishing these different interstate compacts. In fact, one of our administration bills last year was establishing the interstate compact for professional counselors. However, I think this provides an important insight. Many states have not participated in this compact yet, so Maryland's been a leader in this. Georgia has also participated, but because other states haven't, Marylanders don't have access to counselors for critical behavioral health services in neighboring states like Virginia and Delaware. Marylanders can be a leader in maximizing the number of providers available to patients by allowing these out-of-state licensees to serve patients from states that are not in these compacts. We'd be happy to work with any stakeholder groups, including some of the work we've already done with the boards, to make sure that there's an appropriate pathway forward to increase access to behavioral health care practitioners. So for the aforementioned reasons, we respectfully request a favorable report for House Bill 421. And if okay with you, Delegate Kelly, I'd like to turn it over to Dr. Jones.
Absolutely. Dr. Jones.
Good afternoon, Chair Pendergrass, Vice Chair Melnick, and committee members. Thank you for this opportunity to testify in support of House Bill 421. My name is Dr. Allison Jones. I'm currently the Deputy Secretary of the Behavioral Health Administration at the Maryland Department of Health. As Jake spoke to, HB 21 seeks to allow out-of-state providers to provide behavioral health services through telehealth to Maryland residents while still abiding by all applicable Maryland state laws regarding the confidentiality of health information and patients' rights. One of the values underpinning the Behavioral Health Administration's mission and activities is having a responsive system. The behavioral health system of care must be responsive to the people it serves, coherently organized and accessible to those who, and accessible to, I just got kicked out of my computer. Well, it certainly needs to be accessible to those who need services. This bill would certainly allow for that accessibility that we speak to with regards to making sure that people have the providers that they need available. We had a workforce survey done back in 2019 that looked at the availability of providers. And one of the biggest things that we heard from the provider community was the lack of staffing that was available to serve the patients and patients' needs. And we certainly know that during this time that we're in right now, that the pandemic has not made that any easier. Every provider, and honestly in every discipline, is having a difficult time finding providers to provide services at this time. This bill would provide for the expansion of services by improving patient access to healthcare practitioners and communities experiencing a healthcare practitioner shortage across the healthcare industry. As I mentioned, everyone is experiencing such shortages. The passage of this bill would lead to the possibility for more ready access to care, more time to deliver care to vulnerable populations with complex behavioral health needs, more time to collaborate with other care providers for coordination of care, improved ability to refer complicated patients to specialty care that might not be provided in a given state, increased desire to recognize and diagnose those who have behavioral health conditions and non-behavioral health settings because of lack of concern about not being able to find a provider to provide services. On a personal note, I have a friend who's in private practice at this time who's scheduling appointments out 1 year from now. There is a drastic need to increase our ability to any and all providers who are licensed and clinically available to practice and provide services during this time. So for the aforementioned reasons, MDH respectfully requests a favorable report on HB 421 so that all Marylanders can access the care that they need most conveniently. And we would be happy to answer any questions. And please excuse me for my tech challenge. Thank you.
No problem. We all have them. I had some earlier today. So that's the favorable panel. We also have someone signed up favorable with amendments and some unfavorable. So let's take questions now for this panel. Delegate Cullison.
Thank you, Madam Chair. Had to finally unmute. You think I know where it is by now. Thank you, Dr. Jones, for being here and for presenting this. And I want to go back to kind of the last sentence you said. You want to be able to provide the services in the ways that is most convenient and accessible to our Marylanders. Yet you limited 2 programs, cutting them out of telehealth in Medicaid programs over the summer. So I'm confused that we're willing to take out of state licenses at the discretion of each board, but we're not willing to allow our internal state mental health workers to work with those folks that need it. Can you?
Certainly. So you're referring to the limitations that we put on 2 provider types, PRP and residential providers, not saying that they could not provide any services in a telehealth format. That's not what we did. We said that the 2 specific types of services that they each provided would not be able to be provided through telehealth because it was not the most clinically appropriate way to provide those types of services. One of which was providing PRP group services for individuals who have severe and persistent mental illness. The way that the telehealth legislation and the allowances that people have is that you could be in a PRP program and not technically see a person face-to-face for 6 months at a time through the previous way that we were using the telehealth allowances and the way that we're allowing people to operate right now during the Omicron surge. We did not feel that that is appropriate for a long-term way of managing people who have severe and persistent mental illness, because you need to be able to see these people. You need to be able to do mental status exams. You need to be able to see what's going, what their bodies are doing, what they are communicating, not only by their words, but what their actions are doing as well. And you can't do that when you're doing a telehealth visit and you don't have any literal visibility. This meant doing group sessions and you don't even have to have your camera on. And the other thing that we said is if you were in a group home or if you're in a residential treatment program for substance use services, that if you're getting more of those services provided in a telehealth way, then what's the point of you being in a residential program? Part of being in a residential program is having that milieu treatment and providing the majority of your services in a telehealth format. You're not getting milieu therapy. Someone could literally be in their room the entire time that they were in care and not experience any of the interactive experiences that we expect when someone is having residential SGD treatment. And so that was why we put the limitations on those 2 types of treatments only. In a residential setting, you could still continue to receive individual appointments, and in an outpatient PRP environment, you could still continue to have individual appointments in a telehealth format, but not having group treatment, because we don't think that's clinically appropriate. And most of the providers who we were working with, who we have been in consultation with, who are high integral providers, also found that it was not an effective way to deliver care for people who were in a PRP program or people who were in long-term and SUD residential programs. Overutilization of this telehealth also goes against the expectations of what people are expecting when you go into a residential treatment program.
I appreciate that explanation, although I'm still struggling with the fact that we had practitioners come and say that they hadn't seen bad outcomes as the result of having a year of telehealth available to them in these programs. But I think it's, and our telehealth law said clearly that things were going to continue as they were designed during the state of emergency. And it would have given us the opportunity to really study it even more had those programs been continued in the program. So thank you, Madam Chair. Sorry if I took us off track.
No, Delegate Hill, next up.
Thank you, Madam Chair. Thank you, Dr. Jones. First of all, I'm very excited. I think this goes a long way to my concerns about continuity of care that we discussed when I think the last time you were here before this committee. Obviously, there's a lot of opposition that I'm sure you're aware of, and I think there are some things that can probably be worked out. My question is, when we talk about if someone is receiving care under this bill by an out-of-state provider, and there is some infraction or failure to comply with Maryland rules, that we have certain things that are to be done, but one of them says that the state may notify the state where they're licensed. And I'm just saying at the very least that should be a shall. Is there an objection to that? And do you have any additional response to the people who've written to us in opposition and the concerns that they've raised?
I'm going to turn that over to Jake.
Sure. Thank you for the question, Delegate Hill. I think the short answer is we'd be happy to consider that. Additionally, we have spoken to stakeholders. There are some stakeholders who have been in opposition. They've relayed their concerns to us, and we're working with them on that. But that is true, they're in opposition, but it's been a kind of a respectful disagreement.
Okay, thank you.
Delegate Bagnall.
Thank you, Madam Chair. And I'm going to try not to take us off track either, but I'm struggling with this a little bit because of the guardrails we already have with our compacts, which are very carefully crafted, but also in light of the challenges we've had with Medicaid reimbursement, specifically within the behavioral health community. And looking at the bill, I'm unclear as to whether or not this extends to Medicaid. It looks like it does. And should we have the same challenges with out-of-state providers working with the Optum system, do we have the capacity to address those challenges for out-of-state providers that are not under an existing compact?
So thank you for the question, Delegate. The short answer is yes, out-of-state providers can register with the Maryland Medicaid program and deliver services to Maryland recipients. That's over 1 million Marylanders, or about 20% of the population that we can serve with this bill through just the Medicaid program alone. This has already happened, so it's a proven concept, and we think we can effectively make sure that the billing and the appropriate payments go out.
Okay, does that answer your question, Delegate Bagnall? You good? Delegate Johnson.
Thank you, Madam Chairman, and thanks for bringing this bill to us today. Whoever's best to answer. We passed a compact bill last year, and some concerns were raised about the quality or the certificates or education that was needed to practice in Maryland. So I see it says must hold a current, valid, or unrestricted license. Is the educational, do those licenses match what we require for our own Maryland healthcare practitioners? And does this allow Maryland healthcare practitioners to also practice outside the state of Maryland?
So Delegate, I can answer the second question if okay, if Dr. Jones can speak to the educational requirements. So unfortunately, we can't ask other states to participate in these programs, and that's part of the limitation of the interstate compacts. We love the compacts, but unfortunately, we can't make neighboring states join them. So we want to make sure that this avenue is available to Maryland patients so they can have access to those out-of-state licensees.
Since we have one question, one answer, I'm going to go ahead and pose to Dr. Jones the question that Delegate Johnson asked about educational requirements. Can you give us some information about whether we know if there's comparable educational requirements for these out-of-state licensees?
I would need to get more information to answer that question properly.
I think that that's going to be a really essential question to be able to answer as we move forward with this process.
And Madam Chairman, I'm not sure my first question was answered either. Is this going to allow Maryland healthcare practitioners to practice outside of Maryland? This brings healthcare practitioners into Maryland.
No, Maryland practitioners will not be able to serve Maryland patients outside of Maryland unless that state is participating in the compact.
All right, thank you. Thank you, Madam Chairman.
Absolutely. Any further questions for this panel? I do not see any more. The favorable with amendment testimony we have signed up is from Josh Howe. I'm told he's not here. Chairman Pendergrass, do you have a question? I think you're on mute.
I am. Oh, nuts. I worked so hard to find that button. I lost the question. It'll come back. Thank you.
When it comes back, the floor is yours. We were talking about licensing requirements and educational standards and out of state, if that helps. Okay. So I believe Josh Howe is not here. Speak up if you are. We can move on to Scott Tippin, who is unfavorable. Scott, are you here?
Yep, I'm here.
Great.
Thank you, Madam Chair and members of the committee. My name is Scott Tippin. I'm here on behalf of the Social Work Association of Maryland, the Maryland OT Association, the Licensed Professional Counselors, and also the Maryland Nurses Association. We have a lot of concerns about how this bill could impact patient safety, and a lot of those concerns are outlined in our written testimony, so I won't go over all of it. But probably two of the main things we're worried about is one is that this bill doesn't require any sort of notice or registration or certification with any of the state boards, which means no one's going to be double checking if these folks coming from out of state are actually qualified. And then furthermore, if I wanted to file a complaint against my nurse practitioner who's from out of state, and I go to the Board of Nursing, the Board of Nursing might not be able to actually find that person because they never knew that nurse was practicing in the state in the first place. And the other thing has kind of already been brought up a little bit, but this committee has done a lot of work on evaluating and joining interstate compacts. And those compacts have a lot of benefits over this bill. They allow for reciprocal practice between states, and they also ensure that we're sharing disciplinary data between every state who's involved in the compact. And we're just not really sure how this bill interacts with the compacts we've already joined, and worry that it could let folks in to the state who are not qualified to practice under the current compacts. So for those reasons and the other reasons in our written testimony, we think this could have a serious impact on patient safety and ask for an unfavorable report, but I'm happy to answer any questions. Thanks.
It seems as though the chairman has recalled her question. Direct it to whichever panel you would like.
Thank you. It's thanks to Scott Tippin, and I really appreciate this is really not working well. Can you hear me? Good. It's about compacts. If we're going to have compacts and encourage compacts, and the compacts have reciprocity, they have standards, they have all kinds of things that we've agreed to and the other states have, why in the world would be going around the compacts? And I don't think this is for Mr. Tippin. I think that this is for Mr. Whitaker.
Thank you for that question, Madam Chair. And I appreciate the opportunity to clarify. We totally support the compacts. We're in favor and prefer that as the method. This is only in the instances where states choose not to implement the compacts, or in instances like the Counselor's Compact, where other states are implementing a compact, but there's a gap in time where individuals don't get access to services because they can't access those practitioners in other states.
But how can you say that the services that they're not getting might not be subpar because we do not have any real authority over those providers? Maybe it's better to wait and do it right than to do it quickly.
Thank you for the question, Madam Chair. We believe the larger risk is patients not getting access to care. And we want to make sure that patients have access to care that are appropriately licensed, do not have disciplinary issues in other states.
And did you tell me that we're checking that?
Yes.
Thank you.
Thank you, Madam Chair.
Okay. I believe that Robin Elliott is not here because she is in the Senate. So I'm seeing nodding. So that's the end of this panel. Do we have more questions from the committee for Mr. Tippin? Delegate Krebs.
Thank you, Scott. I appreciate your testimony, and I took notes. But the question is, if we have states that are not in the compact, how do we solve the problem? We want to get the people to come here. What is the other? What is another answer?
That's definitely a really hard question. I think my one part of the answer is that when a state doesn't join the compact, it's hard for us here in Maryland to know whether that's just they haven't gotten to it and they're planning to on it, or if that state is not willing to take up some of the very important patient safety things that are built into these compacts. A lot of these compacts require states to work together on discipline, and that's, I think, an important patient safety measure. And so I would just be a little worried about letting states work in the state of Maryland if they weren't willing to take up those disciplinary obligations that exist under the compacts. But I know at least for the professional counselor compact, we've been talking extensively with the Lieutenant Governor's office to try to promote that compact in other states, and trying to get states to pick it up because we just really think it's such an important compact.
Yeah, and I don't know if it's in our packet somewhere, but I think it'd be nice for the committee to know who's in the compacts with us and who's not. Where are we lacking? And it might be somewhere in all this testimony, but it might be helpful for us to articulate how broad this is. But thank you.
Thanks.
Delegate Hill.
Thank you, Madam Chair. Hey, Scott. So I'm excited about this for a different reason than the sponsors, right? So I'm concerned about continuity of care. And so I'm wondering what your thoughts would be if this were limited to persons who've already established prior to coming to Maryland, we're off at college, whatever, they've established a relationship, that we didn't allow folks outside of the compact to solicit or get new patients, which is a little different from the sponsors, but that people could continue their own relationship with a licensed professional in another state, whether we limit it to up to 6 months or up to a year. This might be a vehicle for that. Do you have any thoughts about that?
I think that's a really interesting question. It's interesting that you brought it up, but this is just for MASW, so the social workers. At the last meeting we had with them, there was a lot of conversation about this exact question. And I think we kind of landed on, we weren't exactly sure how to craft an amendment that gets to that point, or even if that would really solve all of our questions about the bill. But I think it's definitely an interesting question. I think it definitely is a slightly different question than, the administration is looking at. But I'd be happy to chat about that more precise question offline, if that's helpful.
Sounds like a plan. Thank you.
Thanks.
Wonderful. Do we have any further questions for this panel? I don't see any more. So with that, we're going to conclude the hearing on House Bill 421. To the committee, we have 3 more bills, but I think it's a good time for us to take our 30-minute break so that people can drop their bills before the 5 p.m. deadline, which is today at 5 p.m. So it is 3:20. We will return at 3:50 to finish the last 3 bills of the day. All right, it is 3:49, so people might want to start getting back to turning on their cameras. Did everybody have a nice break? Yes. I got my bills dropped, so thank you. I saw a couple of our colleagues over there. All right, I think it is time for us to come back. I see the committee has convened. I see the chairman is here and her bill is next, which is House Bill 536. Is everybody ready to reconvene the hearings? Wonderful. So we are going to have the hearing now on House Bill 536, Maryland Insurance Commissioner Authority Federal Health Emergency. Chairman Pendergrass.
Thank you, Madam Chair. This is something that came out of conversations with the insurance commissioner over time during this pandemic. There were, when we were in a Maryland state of emergency, there were certain things that could be done because of that. When that went away, her powers became somewhat limited. And the concern is that fortunately, she had the good working relationship with the carriers, and everybody figured out ways to do the things that did need to be done in a voluntary way. But it's conceivable that in the future, the authority might need to be with the insurance commissioner as long as there is still a federal health crisis. So with that, I would ask their panel to explain.
The panel from the insurance commissioners? Okay,
Yes.
let's, I don't have any witnesses listed, but I'm going to assume that we have, I see Commissioner Barain on, so we'll go to her.
Great.
Thank you. And I apologize if we were late signing up.
No,
So
it's important to hear from you.
Thank you, Madam Chair, Madam Vice Chair, and members of the committee. I'm very pleased to speak in favor of House Bill 536. House Bill 536 does two things. First, it will authorize the insurance commissioner to activate emergency powers when there is a federally declared health emergency that impacts the state. This puts health emergencies on par with federally declared natural disasters. Currently, our power to act when there is a federal declaration is limited to natural disasters. Including a federal health emergency expands the scope of the extreme circumstances in which we can act to protect consumers. Secondly, the bill includes uncodified text that assures that Medicaid enrollees who have enrolled in Medicare during the federal health emergency are able to acquire Medicare supplemental insurance on a guarantee issue basis. So when you enroll in Medicare, you have a 6-month period to obtain a Medicare supplemental insurance policy without medical underwriting. So under normal circumstances, when a person who is enrolled in Medicaid becomes eligible for Medicare, Medicaid coverage ends, Medicare coverage begins, and a Medicare sub policy can be obtained without medical underwriting for 6 months. However, during the federal health emergency, the federal government has not terminated coverage for Medicaid enrollees when they also enroll in Medicare. Because their Medicaid coverage continued, none of those new Medicare enrollees were eligible to apply for a Medicare sub policy. That's because insurers are prohibited from enrolling someone in a Medicare sub product if the person has other coverage that would duplicate those benefits, and Medicaid benefits are duplicate coverage. Because of the length of the federal health emergency, the 6-month special enrollment period has now expired for most people who are in both Medicare and Medicaid. When the federal emergency ends and those people are disenrolled from Medicaid immediately, they will need to buy Medicare supplemental coverage, but they won't be able to do it on a guarantee issue basis. What this bill does is it restores that opportunity, and it gives people in that very unique situation a 61-day period after they are terminated from Medicaid to still obtain Medicare supplemental insurance without underwriting. So I thank you, Madam Chair, for proposing this legislation and for the opportunity to speak in support of it. We urge a favorable report.
Thank you. Was there anyone else from the MIA that needed to speak on this bill, Commissioner?
No, it was just me.
Wonderful.
And I'll also just add that we have had no opposition or concerns from industry at all about this bill.
Great. Any questions from the committee on this bill? I don't see any questions, and we do not have anyone signed up to testify in the unfavorable, so that concludes the hearing on House Bill 536. Thank you very much.
Thank you. Take care.
You too. 2 more bills. The next bill is House Bill 625. That is a Delegate Kelly bill, the Commission to Study the Healthcare Workforce Crisis in Maryland. I will introduce this and try to be pretty efficient and then move on to the proponents. We've heard a lot of conversation today and the last couple of weeks about the real crisis in the healthcare workforce. I talked to the committee about this last week with some bills and mentioned we're going to be seeing just a number of bills trying to really make some significant improvements. So this is, obviously from the title, it's a commission bill. I don't particularly try to do work groups or commissions, but I think in this situation, having worked with stakeholders over the interim to really try to grapple with this challenge, I felt like it was warranted, and the response has been really great from stakeholders who feel like we need to get people together to try and address this issue. As the committee knows, even pre-pandemic, there was growing recognition that our healthcare workforce was insufficient to meet Marylanders' needs in certain areas and certain specialties. The pandemic obviously exacerbated these challenges, and today's vacancy rates are really high. They demonstrate that need. In addition, of course, we have an aging population. We have increased numbers of insured Marylanders, which is great. And we have an increase in healthcare innovation that leads to greater need for more robust healthcare workforce in the future. So as I mentioned, I was having a lot of discussions with stakeholders in this space, and it really became clear that we need a lot more interagency cooperation and communication, that communication is really lacking. And so we need this commission to serve sort of as a broad study of current and future needs. Just a little bit of data. I don't want to bore you guys. We do this every day, but I'm sure the American Hospital Association will tell you that job postings for nurses are up 45% nationwide since January 2020. 45% for nurses and 41% for other clinical staff. The U.S. Bureau of Labor Statistics expects 500,000 more nurses will leave the workforce this year, really increasing that national shortage to 1.1 million nurses. Maryland hospitals have over 3,900 nursing vacancies, a 50% jump just since August. I mean, think about this, right? It's having a huge impact. The ARC reports a 30% vacancy rate for direct support professionals. I could go on and on, but we talk about this every day. So I think you all know the severity of the issue. We structured a commission so that it would convene sort of work groups and advisory committees When you try and build something like this, of course, so many different stakeholders want to be included, and we want to create a structure that will allow for them to be included, but without having hundreds of people serving on this commission. So that's the structure that was advised that I think will work for us. There are amendments. I have a sponsor amendment. I worked with a lot of the interested parties to make sure, for example, there's a may convene work groups language in the initial bill that's going to change to shall, just to make sure we're being explicit that we want these industry stakeholders, worker representatives, community, colleges, et cetera, included in these conversations. It's got to look at a number of different things. Again, the language probably needs a little bit of refinement, and so I expect to be working on that with the stakeholders that you'll hear from. But really looking at the extent of workforce shortages, short-term solutions, board backlogs, licensing flexibility, current training, education, and apprenticeship programs, the future healthcare workforce needs, really a number of different issues that have come up that we need to dig a little bit deeper into. I touched on the sponsor amendment. This is a 2-year commission. It's going to give us 2 reports in December. So that's really the structure. And with that, I'm going to say, we're going to work on refining the language a little bit to make sure that this is a commission that's going to meet our needs and give this committee some really important information as we make these decisions moving forward. So with that, I'm going to urge a favorable report. And then I will call other stakeholders to testify in support. So we have Erin Dorian from the Maryland Hospital Association.
Thank you, Madam Chair, and thank you for introducing this legislation. For the record, Erin Dorian, the Vice President of Policy for the Maryland Hospital Association. I don't think I can say it any better than Delegate Kelly did, what this commission will do. I just want to put a point on something she brought up, that the commission envisioned in the legislation brings together multiple agencies to look at the root causes of our workforce crisis, as well as develop both short and long-term solutions. I don't need to blast you all with data. You know how bad the problem is right now. The hospital field fully supports this effort. We're ready to engage in this bill as it moves through the legislative process and participate in any capacity with the commission. So we urge a favorable report on House Bill 625. And with that, I will yield the rest of my time.
So much. Next up is Allison Sibirowski.
Thank you, Delegate Kelly, and hello, Madam Chair, members of the committee. For the record, I'm Allison Sibirowski here today on behalf of Leading Age Maryland. We support House Bill 625, and you have a written testimony. As noted before, we represent nonprofit aging services providers in Maryland, and we fully support that this bill would establish a commission to look at the challenges related to workforce recruitment and retention and development in our state. There are many groups that are working on workforce issues in our state, and I think that this commission has the potential to really be a central clearinghouse and convener, and to really look at these things in a comprehensive way. This is a complex issue that will require thoughtful, comprehensive, and creative solutions. And so we fully support this initiative and are excited about the opportunity to engage any way that we can. As Delegate Kelly mentioned, there are many different groups that have interest in being involved, and we feel that those closest to the challenges must be included in the dialogue to ensure that the solutions that are proposed will have a sustainable impact. So we thank the sponsor for including an amendment that specifies how industry representation will be included. For these reasons, we respectfully request a favorable report for House Bill 625. Thank you.
Robin Elliott.
She looks like she did not make it back.
She has to be over in the Senate. Do we have Scott Tippin here?
Yep, I'm here.
Excellent.
Thank you, Madam Chair, members of the committee. Again, my name is Scott Tippin. I'm here on behalf of the social workers, as well as the school psychologists and the Maryland Nursing Association. I won't, really go into our amendments at all, because we've already been talking to Delegate Kelly about trying to integrate some of that stuff. But just wanted to express our support of this bill because of the huge workforce shortages we're having, especially in our schools and community behavioral health clinics. So I'm really excited to hear you guys are working on this bill. Thank you. I'm happy to answer any questions.
That is everybody signed up in support. Do we have questions from the committee? I see no hands. Giving you a second just in case. Excellent. We do have someone signed up in opposition. It is Vince McAvoy. I don't know if he's, Delegate Lewis Young. I'm sorry. Go ahead, Delegate Lewis Young.
Thank you so much. I have a sticky hand today. I apologize. Thank you, Madam Chair, for this bill. It's very timely, and I also appreciate that it acknowledges that we need both a short-term and a long-term solution. I want to ask a question about the shorter-term solution. There are already several pieces of legislation in this session dealing with anxiety, stress, safety. Is there a way that we can look at those issues holistically within the framework of the intent of this bill, as opposed to having those issues in silos the way they are presented today?
I think I understand your question, but I'm not positive. It sounds like the answer is yes. It's always a better way is to look holistically. So I support that.
Well, I mean, the reason I'm asking the question, for example, I have a bill in threats against healthcare workers. We all know there have been numerous threats, and safety is an issue. And I'm sure there are other bills that, if they haven't come across our computer yet, we'll be seeing them. And so, as a short-term approach, is there a way we can look at these isolated efforts and try to link them together before we have the longer term response from a work group study?
Yes, I see what you're saying. And absolutely, I think that makes perfect sense. And I would be happy to work with you on that.
Thank you.
Absolutely. I was going to call Vince McAvoy, but he is not here. So with that, we're going to conclude the hearing on House Bill 625. Thank you. One final bill for the day, House Bill 670, which is Delegate Wilkins' bill, Maryland Healthcare Commission Study on Expansion of Interstate Telehealth. Is Delegate Wilkins? Oh, there she is. Hello, welcome, Delegate Wilkins.
Good afternoon. Great to see everyone. I do want to mention very quickly that if I turn my camera off suddenly, we are about to vote in Ways and Means. So I do apologize for that, but I do want to present the bill. And thank you again, everyone. For the record, I am State Delegate Janelle Wilkins, pleased to present HB 670, which is a bill related to expansion of interstate telehealth. I am so grateful for the work that this committee has led on numerous issues related to telehealth, particularly during this pandemic. And we know that telehealth has emerged as a critical solution for prevention, diagnosis, and treatment of COVID-19, but also numerous ways that patients have been able to access telehealth as well. And during this unprecedented demand for virtual care during the pandemic, an executive order temporarily allowed Maryland residents virtual access to doctors out of state. I'm bringing this bill related to expanding access to interstate telehealth after several constituents reached out to me about the need to virtually access telehealth. One of these constituents that's hopefully able to join us next is Grant, who you'll hear from today, who has an aggressive form of cancer and unsuccessfully sought access to telehealth services for a specialist he really needed in Texas. Residents want the best provider and the highest level of care that suits their unique healthcare needs, regardless of state lines. Interstate telehealth expands the provider choices for Maryland residents, and in some cases, access to specialists that might be limited or unavailable here in Maryland. But we have to make sure that implementation and access to greater interstate telehealth services is done in a way that has the highest standard of care, and it protects the patients and the providers as well. So after talking with several of you on the committee and meeting with various stakeholders, I came to the conclusion that there seems to be general broad agreement in terms of expansion of interstate telehealth and looking at how we can provide and expand those services, but it's not quite simple on how we do it. And it really requires expert study. As you know, in 2020, your committee made the wise decision to task the Maryland Healthcare Commission with a work group that studied and looked at various aspects of telehealth, and they put forth a report last year. And they also have a qualitative study that is underway. HB 670 requires the Maryland Healthcare Commission to convene the appropriate stakeholders to study and make recommendations on how the state can move forward with expanding interstate telehealth services. Although this is a study bill, I know that that can be challenging. I do think that this is such a complex issue that it's so critical that we bring together the experts and the stakeholders to look at the layers of challenges and issues and opportunities that we have. I know there was earlier conversation in this committee about compacts in particular, and that's one of the great reasons why I think this bill would be helpful to ensure that we're looking at places that we might be missing in our compacts, ways that we can expand access, and so on and so forth. So finally, I do want to point out that there are some differing opinions on who should lead this study, the scope of the study, the membership of the study. And I'm totally open to how it can be done. I leave it to this wise committee to chart forth the best option for us as a state to figure this out. But I would like to urge a favorable report on HB 670, and thank you all so much for your time.
Delegate Wilkins, I see Grant Smith is here. Grant Smith.
Thank you. Good afternoon. My name is Grant Smith. I'm a resident of Silver Spring, Maryland. I'm here to support HB 670. I also want to thank Delegate Janelle Wilkins for her leadership on this. Last year, I was diagnosed with having a rare and aggressive form of thyroid cancer. A DC-based provider who I met with gave me a prognosis of about 2 to 5 years and offered me no treatment options. Of course, I wanted a second opinion, and so I sought out specialists in Maryland and as well as in the DC area, and was eventually referred out of state. I ended up at MD Anderson Cancer Center in Houston, Texas, where I met with specialists and they offered me treatment options, and my prognosis has improved dramatically. However, while I was at MD Anderson, they told me that I could not conduct telehealth appointments, even follow-ups, because of the out-of-state restriction in Maryland. This is really frustrating because, of course, I ended up spending thousands of dollars to travel out to Texas to meet with my specialist, including just sit-down appointments to follow up that could have been done over telehealth, right? And so you can learn more about my health situation in my written testimony, but I just want to say that I am very concerned that Maryland's restriction on interstate telehealth really disadvantages Maryland residents in a number of ways. Obviously, there's the financial impact, there's missing work and other responsibilities. Many residents don't have the means to travel just to meet with a specialist. And so I urge the committee to favorably report out HB 670 and ensure that we can have more affordable and more equitable healthcare options, especially for folks like me who couldn't find the specialist they needed in the state. So thank you.
Thank you so much, Mr. Smith. Thank you for being here to share your story with us today. Do we have questions for this panel? I'm going to give the committee a second just to see if there are any hands and let you know we have some favorable with amendment testimony coming. Delegate Hill.
Thank you, Mr. Grant. First of all, I hope that you are here before us in good health and wish you well. And I appreciate your being here. I think this is a huge problem, and it's been a problem ever since, we decided that we needed to step into the space and tell folks how to do. Do you have a sense if the folks at MD Anderson, which is an outstanding institution, had wanted to follow up with you by phone or in some other way without charging your insurance company, if they would have been, so if it was a post-treatment visit that wasn't going to be charged, would our laws, as far as you know, have allowed them to do that? Or is it only when they're going to charge for a visit that it became an issue? Do you have any idea?
What I know is back in June of 2021, when I first met with my specialist at MD Anderson, they expressed frustration that Maryland was one of the only states that they can't work with in terms of patients from this. They can't do telehealth with that state.
Okay.
So they said I had to come back in person. I have been able to have brief phone calls with nurse practitioners there, but it's not been, it's mostly just when I had some urgent things come up, I just needed some immediate assistance.
And those were not charged, correct? So they're allowed to follow up with you, even though that's giving treatment in the state from out of state, but they don't charge for that.
I don't know how that works on the insurance end, but all I know is that they said Maryland's one of the only states in the whole country where they can't conduct telehealth visits.
All right, thank you very much. And thank you, Delegate Wilkins, for this bill.
Thank you so much. So I know Robin Elliott is signed up. I don't think she's back over here yet, but Ann Seacott, is she here?
I sure am.
Excellent.
Hi, thank you, Madam Chair. Members of the committee, I'm Ann Seacott, testifying in support of the bill, House Bill 670, with just a few amendments, or an amendment, a big one amendment. But we thank Delegate Wilkins for bringing the bill forward. And we thank all the work that you all have done. You did just a tremendous amount of work last year on the issue of telehealth. And we are obviously aware that the Healthcare Commission is continuing to its study to see how things are working and where they might not be. And so establishing a commission establishing a study looking very specifically at the out-of-state issues, we think makes sense. What's interesting is earlier this afternoon, there was a related bill on out-of-state telehealth. And I think Delegate Krebs mentioned, we're talking about compacts and talked about, wanting the list of where we have compacts and not. We think that needs to be a part of this study. And that's what the amendments we've submitted suggest, to make sure that we include information about compacts, where they exist, where they don't, where they're in the works in Maryland, because we know that that's, I think in general from the field, the more favored way to go in terms of making those connections with out-of-state providers. So we know that there's going to be a lot of work on telehealth issues the remainder of the session, and we certainly stand ready to contribute in any way we can be helpful.
Thank you very much. That is the end of this panel. Any questions for the favorable with amendment? Just in case, giving you guys a second. That would then be the last witness on this bill. So it concludes the hearing on House Bill 670. Thank you all so much. Thank you, Delegate Wilkins, for joining us. That also ends the work before us today. HGO will be voting tomorrow at 1 p.m. And I believe there's a chairman's meeting after this. Correct? Yes. Thank you so much. Have a good night.